most common jokes about occupational therapy is that no one knows what we do. And this can sadly apply to places where we can be found working. Even recently, some of the insurance companies don't seem to really understand the value or what occupational therapy practitioners do, which is a whole nother level of frustrating. The most common guess seems to be that we help people find jobs or maybe help them while they're on their jobs, which technically isn't what occupational therapy is, though I suppose you actually could do that as an OT practitioner. It also doesn't really help that our scope of practice is really broad. So when someone asks us to explain what it is, it can be a little bit difficult to articulate. The main explanation is that we help people engage in the occupations that are important and necessary for them. And then of course that goes into explaining what the word occupation means in this setting, because people tend to use that word to think we're talking about just like jobs. Occupations are things that people engage in, and that can be work, but it can also be play or activities of daily living, which are things like self-care, brushing your hair, your teeth, stuff like that. It can also be engaging socially with others or just in the community in general. And that's just a little bit of it. So what is it that I do? My name is Stephanie. I'm an autistic adult advocate and certified occupational therapy assistant. As of making this video, I currently work in outpatient pediatrics. That means that generally people from like 0 to around like 20-ish can come into a clinic for occupational therapy, and I might be one of the people that sees them. I am not an occupational therapist, and I'm also not an occupational therapist's assistant. It's kind of a weird terminology, honestly. The biggest difference between the two in terms of functionality is that occupational therapists can do assessments and basically create a treatment plan. They also have a lot more schooling than I have, and they kind of study on different types of assessments and things like that. So they typically will be the people who are booked for all the incoming assessments and reassessments, but they can see clients. But a lot of times they utilize OTAs like me to see clients. Sometimes OTs will also be given the more complex clients, especially if the OTAs on staff are maybe on the newer side. However, that doesn't mean that OTAs can't handle complex cases, and they often do. OTAs can implement the plan of care and collaborate with OT on goals for our clients. For example, if I see something that didn't show up in the assessment, thus I don't see them in the goals, I can talk to my OT, or if there's something especially they're struggling with that might impede the other goals that they have, I might talk with the OT about adding a goal about that specifically, because that's an area that we need to focus on. And as an OTA, I can technically give assessments as long as something called service competency has been achieved. Essentially, it's where the OT makes sure that the OTA can give the assessment with the same level of skill and accuracy as an OT. However, OTAs cannot interpret results, so that has to go to the OT. So we can kind of like implement the assessment, or rather like do the assessment with a client. However, we don't have the ability to score it and see exactly what their responses or how they did things actually means. And that's where the OT has to kind of take over and do all of that kind of paperwork. Both OTs and OTAs can treat clients and educate the clients and their caregivers. I just wanted to quickly give you a simple breakdown of maybe what the difference between an OT and OTA is. Just note that this is kind of broad and pretty simplified. So let's get more specific. What do I even do? So I think the easiest way to explain this is to just come up with imaginary sample clients to kind of walk through what it might look like in a day for me treating different types of clients. So let's pretend my client Jane. She's 7 years old, diagnosed with autism and ADHD. She struggles with handwriting and behaviors at school, so she gets up out of her chair a lot. She kind of shows some aggression. She's gotten in trouble before for hitting and even biting. She basically struggles a lot with her emotional regulation, and she has poor handwriting, which affects her performance at school. So I'll greet Jane in the waiting area to begin our session. It kind of depends on the parent and the client if they want to have like the parent come into the session, which is totally fine. Sometimes parents do and sometimes they don't. In this imaginary case with Jane, she comes into session by herself. Something that I would probably start with for Jane is having her set up a sensory obstacle course. So basically, maybe I could give her a goal of how many steps her obstacle course needs to have, how much time she has to put it together, how many times she can go through it, which usually I'll just kind of give her a time and she can go through it however many times she can in like 5 minutes or something, and then being able to put it away. So this can work on a lot of different skills. First of all, we're targeting sensory integration, being able to get that different types of sensory input. So vestibular, proprioceptive, tactile, all those sorts of things that is going to help her to be able to attend later in our session on things that require more focused attention. This is also going to help her with her bilateral coordination, which is basically coordinating both sides of the body, whether this way or this way. I don't know if that makes sense. Upper body, lower body, or the two sides of the body. A lot of people struggle with this, and this can be showing up in difficulty with handwriting. For Jane, she might have difficulty with her upper body strength, and that might be affecting her fine motor strength. So we have strength that comes from what we call proximal to distal, so closest to the body to the furthest away. Your hand strength is going to suffer if your upper body strength in general is not great. So these are things that this particular activity can work on, as well as executive functioning. As you might know, ADHD has a lot to do with difficulties with executive functioning. I actually do have a playlist going over executive functioning that I'll link somewhere for you if you want to check that out. So this can focus on those executive functions of planning, attention, being able to problem solve if she wants to figure out how to do something, how to go about something. My role during this is to support her skills. So obviously we might cue for safety, basically, is that a safe idea? Maybe we can adjust what we're doing to be a little more safe. The fun thing about OT, of course, in pediatrics especially, is that we can do more risky play. We've got crash pads and mats and everything, but we still want to be within reason. I might need to redirect her to help her remember what she's supposed to be doing in the first place. She could get distracted and go off and do something that has nothing to do with the obstacle course. Or perhaps she keeps on changing her steps and can't remember which step was first, which one was next. And having her plan out how she's going to do this obstacle course and share that with me can help me to keep her on course instead of coming up with infinite numbers of plans that she never actually executes. Also with a timer, especially like a visual timer, she can kind of check and self-monitor to see if she has enough time to actually complete her plan. Overall, eventually, I want her to be able to set that obstacle course up, know how she's going to go about it, tell me the steps, go through them, and successfully complete it within the time allotted. However, it's likely that she's going to need a lot of support in the beginning. Jane's next activity could be something to do with emotional regulation. Maybe we would go over regulation tools. They have a system called the zones of regulation that I would like to kind of talk about in a different video on this channel. But as of right now, I'll just say that basically it's a system that helps kids kind of understand how their body feels with different emotions and kind of classifies them in zones, so that way you can apply tools that are appropriate for each kind of thing for them to be able to regulate. So those who have difficulties with emotional regulation, we might use zones of regulation and then also use those tools to go along with it, so we can kind of come up with a plan where we can regulate before we get to the point of aggression or meltdowns or serious issues, being able to handle our emotions. Another thing we might do is play Uno. So the cool thing about occupational therapy is that we get to treat certain things or target certain things as goals, but through ways that are actually functional for that person. And with kids, that's often play. So we might play Uno, have her over maybe a peanut ball. It's literally like, you know those yoga balls? It's like a yoga ball, but in the shape of a peanut. And it's really good for being able to get kids onto their tummy and put their arms out in front of them. This will allow them to weight bear, so like putting their weight through their upper body, and help her with her strengthening of her upper body, as well as giving her sensory input to help her continue to focus on activities. This also would help with being able to take turns, strategize, be able to handle her emotions if she's not winning or something doesn't go her way, or maybe she gets the draw 4 wild card thing. This also really helps with fine motor skills, being able to pick up one card at a time, like this motion, that's the translation, being able to hold the cards in her hand or hands, being able to shift them to be able to pick the one that she wants. All those sorts of things are skills that we can target through playing a game like Uno. Additionally, we might even work on things like considering that during a strategy game, we don't want other people to see our cards. So working on remembering that we keep our cards like this so that other players don't see what we're doing. This can overall help in social situations because it helps her to understand kind of how this works and others to maybe not take advantage of her not understanding how we might want to approach a game. And we might work directly on handwriting. We can use different tools to help her understand the spacing or the different lines. There's different systems such as handwriting without tears and things like that to be able to use for kind of forming letters in a way that makes sense. But we can also make it into a game, especially if worksheets are something that frustrate her. We might play hangman and she can be the one who's writing on the board and I can be guessing. And this would help her with her upper body strength again, because we're holding up our arm, and then also with her fine motor skills. And so we get some practice in doing that on the vertical surface. Well, the thing is with children, and I guess really people in general, when we have emotional regulation issues, we might not get to everything. We might be spending a lot of our time working through emotions and having difficulty with being able to engage in things that aren't our preference or our choice. So sometimes we might use different tools and techniques for that. So it's just kind of interesting. What my role is often is to kind of cue and support where we're having difficulties. And our end goal is to be able to build up those other skills to be able to complete these things independently. Then at the end of session, we'll go back to Jane's parents and talk about what we did in our session and why we did that and how she did. We might also talk specifically about things we might want to target at home. So if she had trouble holding the cards, maybe we can work on card games at home or other things that involve using our hands in a way that manipulates small items. And sometimes we might give something called a home exercise program, or HEP. So this sounds like you're just gonna do exercises. And in many parts of occupational therapy, especially like with hand therapy, you might literally have actual like exercises. But this can also be things like going over activities they can do at home to target certain skills, educational things for parents regarding issues that they might be having, tools that they can use to assist and support their child at home and in other situations. So I might also give them that. I usually focus on making an HEP for parents who have a specific issue that they struggle with or don't have a lot of information on, and then I try to really give them something that they can find to be useful to target that particular issue. So let's see another pretend client. My next one we'll call John. He's 4 years old and he's been diagnosed with level 3 autism. He has a lot of difficulty with engaging with others, including his parents, especially with play. He likes to play by himself, doesn't like it when people try to engage with him, and often just kind of ignores people. So when it comes to people who have difficulty engaging with others, we're going to take a floor time or DIR floor time approach. I haven't been officially trained yet in like the certification process to be like a special provider that has that certification. However, I have been trained on the basic tenets and basic ideas. So basically the idea is to follow the child's lead and take any sort of communication and honor it. So we want to work on being able to be play partners and have fun together and see each other as a positive thing that we can do things together and that's okay and that it's enjoyable. In this case, often the parents do come in, especially just when they're younger. A lot of times they do, but sometimes they don't. We'll pretend in this case that John's parents do come in. Now, John likes to turn off the light to kind of bring down the sensory stimulation, and he loves having the light projector. Sometimes he'll even bring it to me to show me that he wants it on. He loves the swing, so we'll do a lot of that. Of course, a lot of my autistic kiddos have sensory processing issues, and swinging and crashing and jumping are all things they really enjoy. So we'll use that as an opportunity for back and forth play. We might stop the swinging, ready, set, go! And that go is gonna be when they do something to indicate that they want you to go. That doesn't have to be them literally saying go. In John's case, he doesn't really speak that much. He does have vocalization and a few words, but he doesn't really speak very much. So he might look at me, toward me, he might just wiggle his hand at me or wiggle his foot at me. Something that shows me he wants me to push the swing, and we'll do it again. One of the main goals is just to get that back and forth communication of some kind. whether that's even signing more or saying something or doing something. We want to just get to where we can communicate back and forth and we can enjoy each other's company. There's something called shared joy. So where we just are able to laugh and giggle together and really enjoy the moment. This is actually a goal in this kind of therapy, which I find really awesome and really helpful for engaging children who have difficulty with others. So with John, most of the time we're just going to do whatever he wants. And then I'm going to come in and try to engage with him. I might start with parallel play. So if he's playing with a toy, I have a different toy and I might be playing next to him. Sometimes that might frustrate John. He might not like that I'm playing something that he doesn't want me to play with, or that he just doesn't want me in his space. He might take my items and throw them away, or he might not care. Sometimes it's a toss-up. Other times I might kind of come in, and when he's playing with multiple things, whatever he's doing, if he's like hitting something, I might try, like my turn to try and hit one, not like taking it from him or like interrupting necessarily what he's doing, but just kind of adding to it and kind of working on being able to do that together. Really, a lot of our focus will just be trying to get that reciprocal back and forth response. We'll probably focus mostly on sensory motor play, like with the swing and jumping, maybe giving big squishes. So you have these big crash pads and we kind of sandwich them in there, ready, set, go, and squish, squish, squish. And they love that. And that also gives them input to regulate their sensory system. During this time, I can also comment to parents like, oh, he let me play with him. Or, oh, did you see that smile? I might comment to him about his emotions. Oh, you look happy. You look like you're having fun. He might really like visual stims, and so I might kind of join him, really just try to enter his world. So, and then of course we can talk with parents about like things like ready, set, go, anticipation, honoring any type of communication, that it doesn't have to be words and things like that. My last pretend client is Molly. She's 17 and has a history of trauma. She has suspected autism, but it's not been diagnosed. Most of her issues revolve around not being able to take care of things, so kind of executive functioning and those more simple things like being able to handle a basic chores at home or even just her self-care routine. She also struggles with peer relationships and often will shut down around strangers or when she's challenged. So in Molly's case and most of my teenagers, she comes into a session by herself. A lot of times with teens, we're gonna start with something simple sensory, unless if they're like major sensory seekers. So usually we end up like on the swing or something, and they usually like to kind of just chit chat about things depending on the person. So our imaginary client Molly, she might be telling me about some things that went on this week, and we can take that opportunity while she is getting that sensory input to also kind of have reflective conversation. So being able to talk about how things went, how we handled different things. We might not necessarily use zones of regulation if it doesn't seem to be maybe working for her to use like the zones specifically, but we do talk about like coping skills and what did we do in that situation. We might work on identifying people who are safe to go to in situations where she's upset or scared or anything like that, or who she can find comfort in and who is safe. With Molly, I might go over her daily routine. Maybe we're following up on something we're trying to implement at home. A lot of times we're working on schedules and being able to figure out how to plan things, break things down into steps. Maybe if she has chores at home, say that she has laundry, I might have some clothes that are clean at the clinic for her to fold, and we might go over tips of how to find out if it's inside out and what we can do about that. Maybe sorting things by sizes or colors or things like that. Just basically our skills that we need to be able to do the things in our life that we need to. I might take her to a messy treatment room, ask her to make a plan of how she would clean it up. And we might also try to execute that plan, maybe give a time estimation. So we can work on several executive functioning skills and practical life skills. We could go over, brushing our hair and how that works. And a lot of times we'll have them bring things to the clinic to be able to complete that. And then of course there's the fun things. We might play more advanced games that require problem solving and critical thinking, or we might play games mostly just to focus on the social aspect. So we might join other clients and their practitioners to be able to play a game, and then she can be in a social situation with me there as a support, and also other people maybe mediating other clients as well, so that way they can have positive social interactions. So at the end of Molly's session, of course, we'll go back to the parent and we'll discuss again, what we did. For example, we might talk about the calming strategies we went over in session, and I might give them a copy of that or a at least brief them on that so they can kind of help them and prompt them, okay, so this is happening. What if we try doing that thing from OT? If we try a breathing technique? What if we try this or that? When I have a break between sessions or at the end of the day, especially if it's a busy day, then I'm going to be writing notes on every single client that I've seen. So this is the process where essentially I'll like give the time, we'll do like codes for different things. So there's therapy codes you build. It's for insurance sorts of things we have to know a little bit about. And then we're going to talk about what we did in session, why we did that, what that targeted, what their skills were in that session, if they had difficulty with fine motor skills, difficulty with problem solving, things like that. My notes can look wildly different depending on the client. And what I mean by that is, for example, my floor time kiddo, John, that we talked about earlier, we might be talking about circles of communication and shared joy and how many times we interacted at all. Whereas with, Molly, I might be talking about how well she was able to sequence something or be able to attend to a task or follow a list. So these sorts of things are very different, very unique to each person. But basically, my job is to say exactly what happened, how they did, and essentially that gets shared with the insurance company so they can be like, yeah, we'll pay for that. Sometimes I'll also do what is called a progress note. So basically this is a more in-depth note going over all the goals, not just specific to that session. So it's not really talking about like, we did this and this is why. It's more like over the last however many sessions, I've been seeing this trend. We've gotten better with our translation and fine motor. We're still showing issues with understanding how things affect us. So just different things, and we'll kind of write a little thing around each goal and then give an overall assessment. A lot of times progress notes are for insurance companies so they can see if there's been progress and if there is still a need for skilled occupational therapy. So it's essentially my job to show why this person still needs to be covered by insurance if that's the case. And then of course there's smaller things, obviously, of being able to clean up after our treatment. And I might work on treatment plans and ideas, especially if they need more planning and forethought or are more complex that I want to do with certain clients, or I might be writing up an HEP for somebody that I want to have ready for the next time I see them. So hopefully that explains a little bit of what I do as an occupational therapy assistant working in outpatient pediatrics. I always kind of wondered what exactly someone does when they say like, oh, I do XYZ. So I thought it'd be fun to just kind of come up with some imaginary clients and go over what I actually do on a day-to-day basis when I'm at work. So I hope you enjoyed it. I hope it was insightful about what occupational therapy is and what it can look like in pediatric outpatient. And if you follow me just in general, what I even do. So thank you so much for watching. I hope you have a wonderful week and I'll see you in my next video. Bye.